Good afternoon. Thanks, Mike. So we've heard already at this board review course that brain tumors are the very worst topic. We've heard that coagulation is the very worst topic. I want to know how many people in this room that statistics is the worst topic. See, it's good to be best at something. So this is not a talk that's designed to teach you research methods. This is a talk that's designed to have you pass the boards. As such, the way that I've laid out these slides will seem very choppy, it won't flow, but it's to help you study as the order completely follows the way your syllabus is written. The other thing to tell you is I've been told that there are not many questions on research methods. So you might want to think about that as you're allocating your study time, but I will point to the repeated questions from the boards and really encourage you to learn those specific slides if you're pressed for time. So I have no financial disclosures. The outline of this talk is going to follow these three sections: principles of use of biostatistics in research, principles of epidemiology and clinical research design, and applying research to clinical practice. And for each of these sessions, what you're going to see are these tables that show you the specific points in your syllabus and which slides they are addressed in. So we're going to start with variables and data because that's the foundations of how you know how to do statistics. So we first have to be able to describe data, and data can be binary or dichotomous, so yes, no, boys, girls. They can be categorical or nominal. So these are categories such as leukemia type, AML, ALL, CML, where there's no relationship between the different categories. So ALL isn't more or better than AML, they're just different categories. Ordinal data are when there is an order to the data, but you can't do math with them. So for example, here this is CTCAE toxicity. This is the toxicity grading scale used by the NCI on all COG clinical trials. Grades 1 to 5, 1 is the mildest, 5 is dead. So 2 is worse than 1, 3 is worse than 2, but you can't do math with it. So grade 4 is not twice as bad as grade 2. Continuous outcomes you're going to be used to, like serum creatinine, age, weight, BMI. And then survival is just time to an event. It could be any event. It doesn't have to be time to death. It could be time to first job. It could be time to first marriage. It could be time to anything. So what the board wants you to know is that the nature of the outcome variable, so dichotomous, categorical, ordinal, or survival, drives the choice of statistical tests, and we're going to come back to that in a couple of slides. We have to describe our data, and for continuous data, we need to describe some measure of central tendency. So this includes mean, which is the average value, the median, which is the middle value, and the mode, which is the most common. So if your data are nice and normally distributed like this bell-shaped curve, the mean, median, and mode are all the same. If your data are skewed like this curve on the right, the mean, median, and mode will be different. And the board wants you to know the distribution, whether your data are skewed or normal, also drives your choice of statistical test. We also have to be able to describe some measure of variability. Standard deviation is the average spread from the mean, and the wider your standard deviation, the greater the variability in your data set. A standard error is a special type of standard deviation. It's a standard deviation of population means, and it's standard deviation divided by square root n. So hypothesis testing drives many of the clinical trials that we design. When we design a comparative trial, we start by defining the null hypothesis. So that's that treatment doesn't work. So for example, if we're going to do a study of whether prophylactic levofloxacin reduces bacteremia, my null hypothesis would be is that it does not reduce bacteremia. And your alternative hypothesis is what you're really hoping to show, is that your treatment works or that prophylaxis is effective at reducing bacteremia. All of statistics is about determining the probability of seeing data as extreme or more extreme as what you actually saw, assuming the treatment doesn't work. And if that probability is really small, we reject the null hypothesis and we conclude our treatment is effective. This will be more clear on this slide. All of statistics is really about calculating some test statistic. So in this slide, it's a Z, but it could be a T, it could be a chi-square, it could be an F. And all of these test statistics follow some distribution under the null hypothesis. So most of the values are going to be in this middle area, close to 0. But by chance alone, sometimes these test statistics will fall in these extreme areas. And at some point you say, it is so unlikely that I would have seen that test statistic. Assuming the null hypothesis, this allows me to reject the null hypothesis and conclude my treatment works. Now, how rare is rare enough? By convention, we say that's a p-value of 0.05, and that's our alpha error or type 1 error. So the board wants you to know that the nature of the outcome variable drives your choice of statistical tests, and the distribution also drives your statistical test, and I'm going to show this on the next slide. So there are 2 tables that you need to memorize to know how to do statistics. The first table is where your outcome is continuous. And then you would need to see, do I have 2 groups of interest or 3 or more groups? My next decision point is, are my distribution parametric or non-parametric? So parametric can just be translated into saying, do I have that nice normal distribution that I saw before? And if the data are parametric and I have 2 groups, I would do a student's t-test. If I had a non-parametric distribution, the board calls it a Mann-Whitney U-test, but today most people would call it a Wilcoxon-Rank sum test. And if I have 3 or more groups, and if I have a parametric distribution, I would do an analysis of variance, and the non-parametric equivalent is the Kreska-Wallace test. So there's no way around this other than just memorizing this table, that you can't logic your way through this table. So what is the student's t-test? A student's t-test is about calculating a test statistic. And what test statistic do you think we would calculate? So it's a t statistic in a student's t-test. Conceptually, what a t is, remember we've got 2 groups and a continuous outcome measure. The t statistic is the difference between the means of my 2 groups divided by how variable my data are within each group. So you can see that as that mean difference increases, either really positive or really negative, I'm going to be more likely to be in that tail of that bell-shaped curve that I showed you. The larger the t, the smaller your p, the more likely you are to reject your null hypothesis and conclude my 2 groups are different. This assumes the data are normally distributed and that your observations are independent. So we're going to talk a little bit about matched data in a couple of slides, but if your data are matched, you have to use a paired t-test. So I told you there were 2 tables. One was if your data are continuous. The second is if your data are dichotomous or binary. Here, if you have 2 or more groups of interest or exposure variables, you would do a chi-square or Fisher's exact test. So in a chi-square test, what test statistic do you think we would calculate? It's going to be the chi-square statistic. So here we've got a 2x2 table. This is the most common thing that you're going to see. Let's say that the question that I want to ask is hyperleukocytosis defined by a white count greater than 200,000 associated with induction death? Yes or no? What a chi-squared statistic does is it says, okay, I know the number of kids I have with hyperleukocytosis. I know the number of kids who have died. I should be able to figure out what each of these cells would be by chance alone. What a chi-squared is doing is it takes what we saw minus what we expected, does a little bit of math with it, adds them all together, and the bigger your chi-square, the more likely you are to say this didn't occur by chance alone. You'd have a smaller p-value, you'd reject your null hypothesis, and you would conclude that there's some relationship between white count and induction death. So I said I would get back to this issue of matched or paired data. So this is really important in knowing the appropriate statistical approach to take. And it's really asking, are my exposure groups independent of one another? So every randomized trial will have independent groups. It would be logistically almost impossible to have some sort of match design. The most common ways to induce matching, probably the most common way that we see, are pre-post intervention. So for example, you might ask the question, does leukapheresis reduce the white count? What you would do is you would measure the white count before the procedure, you would do the procedure, you measure the white count after the procedure. So here you're comparing white counts within a single individual. That's an example of a matched design because it's comparisons within a person. Another example of a matched design would be a crossover trial. So many of the clinical trials of GCSF were initially crossover trials, where you would take a patient, give them chemotherapy, you'd randomize them to get either GCSF or placebo, and then the next cycle they would get the alternative approach. So they might get GCSF and placebo, or placebo and GCSF. And here the comparisons again are within individuals. They're not between different individuals, and that's why that design is matched. We can also create matching in observational trials, and the most common time that that's used is within case control studies. So let's say that we're doing a case control study and we want to see whether there's an association between maternal smoking and infant ALL. What you're going to do is you're going to find a bunch of kids with infant ALL, and now we need to find controls without infant ALL. And it would be very common to match 1-to-1, 1-to-2, or 1-to-3. So every patient with infant ALL, you'd find a kid without ALL, and you might match them by age, by geography, by socioeconomic status, so that for each child with ALL, there's a specific control child that's been linked to that child. And you have to account for that linking in the analysis. So p-values. So p-value is the probability of obtaining a test statistic as at least as extreme as the one you actually observed, assuming the null hypothesis is true. So what does that mean really for us? It means what's the chance that you saw the result you did, assuming that the treatment doesn't work? So 5% p-value means that assuming that the treatment doesn't work, there's a 5% chance of seeing the result you saw by chance alone. So this becomes important. Let me go back to 1- and 2-sided p-values. So a 2-sided p-value is when you evaluate both the chance that your treatment is better or worse than your control intervention. And I think that's important because sometimes we're wrong and sometimes the treatment is actually worse than our standard regimen. And what you do here is you allot your alpha value or your type 1 error equally between the two ends on this graph, so 2.5 for each tail. And I just want you to note the Z here that defines a significant value is 1.96. In a one-sided p-value, we're saying we are completely ignoring the chance that my treatment is worse. I'm going to put all my alpha error or my type 1 error on one side. And you'll see here my Z is 1.6, so it becomes easier to reject the null hypothesis if you have a one-sided p-value. And it's less commonly used in general across research, although the NCI seems to have a tendency towards one-sided p-values these days. So what I told you before is that a p of 0.05 means that there's a 5% chance of seeing the chance by the data, having a significant value by chance alone, assuming the treatment doesn't work. So we do multiple tests. If we do 20 tests, our chances become very high of finding at least one significant value. And that's the issue of multiple testing. And that's why it's important to establish a single primary outcome, or you might have to adjust your p-value to account for multiple testing. A Bonferroni correction is just when you divide your target p-value by the number of tests you do. So a Bonferroni correction, if you're doing 2 tests, your target p-value would be a p of 0.025. Actually, I should have mentioned earlier on that I will tell you some information to help put things into context, but if it's not on your slide, it is not an ABP objective or in your syllabus, and that's why I have not included it. So the confidence interval is the probability that an interval contains the true parameter. So let's put this into an example. So a 95% confidence interval around the mean, that's probably the most common one that we'll use, means that there's a 95% chance that the interval will contain the true mean. So it means that if we do 100 clinical trials, 95 of these intervals will contain the true mean. So errors are, we've already alluded a little bit to errors. Errors are important when you're doing hypothesis testing. This is the truth. This is our study and what we conclude. In an ideal world, we will find a difference from our study when one really exists, and this is related to power or sensitivity, or we will not find a difference when one really doesn't exist. So these 2 quarters are the ideal situation. There are 2 types of errors that can occur. Type 1 or alpha error is when we conclude that there is a difference when one doesn't exist. We've already talked a little bit about this issue. This is this type 1 or alpha error that we usually set at 0.05, and this can be considered a false positive. The other kind of error is a type 2 or beta error, where we fail to find a difference in our study, but one really does exist, and this can be considered a false negative. And these become important when we calculate sample size, as I'll allude to later. This is the first chart you must memorize. Please memorize this chart, and I'm going to do this every time that I really think there's going to be a question on your exam. So all of these measures of associations are highly testable and usually are tested. The way that I would recommend you do this is set up your tables the same way all the time and just memorize the formula, and do this somewhere like a week before your exam. It's really good to try to understand it, but I think we're trying to be pragmatic here. So I always set up these tables. This is the way I do it. I always set up that the outcome's on top, because the outcome's the most important thing. And I always set up my treatment groups on the left. And the calculations that we're going to do for this slide are absolute risk reduction, relative risk reduction, and number needed to treat. So to do absolute risk reduction, figure out what your risk of your outcome in your treatment group is, which is A over A plus B. Figure out your risk of your outcome in your control group, which is C over C plus D. And your absolute risk reduction is just the difference in those two risks. Relative risk reduction is the absolute risk reduction divided by the event rate in the control arm, and the number needed to treat is 1 over the absolute risk reduction. In this case, it's 3.3, which would mean you'd have to treat 3 individuals to prevent 1 bad outcome compared to the control intervention alone. Please memorize this table as well. This is highly likely to be on your exam. This is calculating relative risks and odds ratios. Again, just set up your table the same way every time, where I've set it up with the outcome on the top, the treatment groups, and the control group on the left. We've already described what the risk of the outcome in the treatment and the control group are. So the risk in the treatment group is A over A plus B. The risk in the control group is C over C plus D. The relative risk is simply the ratio of those two risks, relative risk. And a relative risk of 2.5 means that your risk of your outcome is 2.5 higher if you were exposed or in the treatment group. Odds ratios are a bit different. Think about odds like horse racing. I don't know how many people do that anymore. But, you think about gambling and horse racing, and people always talk about 2-to-1 odds. So here you're not looking at A over A plus B, but rather the ratio of A to B. So the odds of your outcome in your treatment group is A over B. Your odds of your outcome in your control group is C over D. So your odds ratio is the ratio of those two numbers. But honestly, I would just memorize it this way. A times D over B times C. Just remember that and you'll be good. And an odds ratio of 2.5 just means that your odds of an outcome are 2.5-fold higher if you were exposed or in the treatment group. Your odds ratio and your relative risk become very similar when your prevalence of your disease becomes rare. The board also wants you to know that your hazard ratio is something that comes from a Cox proportional hazards model in survival statistics. That hazard ratio is very analogous to a relative risk. When the correlation coefficient is something that we calculate when we have a continuous exposure and a continuous outcome variable. There are two types of correlation coefficients. There's a Pearson and a Spearman. The Pearson is used for parametric data. A Spearman is used for non-parametric data. You note that none of that data information is on the slide. It's because it's not in your syllabus, so I wouldn't memorize it. R of 1 means perfect positive correlation, and R of -1 is perfect negative correlation. I just wanted to emphasize that correlation is not the same thing of concordance. Let's say that we were comparing parent assessment of quality of life and child self-report of quality of life. A parent could always mark quality of life as 2 points higher consistently. That would be perfect correlation, but 0 concordance. Concordance means are the same. So regression. Regression is something else the board wants you to know about. I think about regression as a way to just define relationships between one or more exposure variables and an outcome, or to try to predict that outcome. So most typically we use regression because we have a primary exposure variable. For example, let's say hypothetically we've done a randomized trial of prophylactic levofloxacin. We want to know if it reduces bacteremia. We might use multiple regression to adjust for confounders so that we can measure the independent effect of prophylactic levofloxacin. We can also use regression as a way to predict an outcome. So let's say I want to predict the risk of bacteremia in a bunch of kids with cancer. I just take every risk factor that I think that might be associated with bacteremia and try to put them together in a model to see if I can get the best prediction possible. Univariate regression is when you have one exposure, one outcome variable. Multiple regression is multiple exposure variables, so this idea of adjustment or multiple variables in a prediction model, and a single outcome. So just like when I talked about the types of statistical tests you would use before, the type of regression depends on the nature of the outcome variable. If your outcome is dichotomous, so let's say I want to predict induction death, you would use logistic regression analysis. Logistic comes from log odds, and that's how you might be able to remember. Logistic relates to binary data. If your data are continuous, you would use linear regression. And if your data are survival, there are lots of different approaches you can use. Cox proportional hazards model is probably one of the most common approaches that's used. So in survival analysis, my outcome is time to event. It could be time to any event. It doesn't have to be a live or die event. And the advantage of a survival analysis, it allows you to censor patients who don't have an event when they were last observed. And most data are right censored. And this example will probably make this more clear. So let's say this is a study of AML. All kids with AML don't get diagnosed the same day, so we always have staggered start dates. So this child is enrolled. Let's say this child lives for 2 years and dies. So this child's survival time is 2 years and has the event, death. This next child is diagnosed a year later and survives for 4 years, and we stop the study on this day. So I know that this child has lived for 4 years. I don't know if the child's going to die tomorrow or a year from now or 10 years from now. All I know is today that child is still alive, and I censor that child on that date or 4 years. The next child is diagnosed a year later, survives for 2 years and dies and has the event. In statistics, this child that lives for 2 years and dies looks exactly the same as this child that lives for 2 years and dies. So there's nothing about the order of enrollment that impacts on the statistics. This next child is enrolled, lives for 2 years, and this is censored after 2 years. So Kaplan-Meier is the most common way that we use to describe survival data. What the Kaplan-Meier approach does is it recalculates the survival probability every time one or more child experiences the event, and it takes care of dropouts at the next time there's an event. And so you're probably all used to this, but the way that we normally describe this curve is we identify some time point we're interested, like 3 years, 30 months, 5 years, and we simply read up what survival is at that time point. So in this example, 30-month survival is 40%. So we use survival analysis when we have time to event data where each individual will have different lengths of follow-up and where we need to censor patients either because they haven't experienced the event at the time we stop the study or because patients may be lost to follow-up. Here is the next slide that I would urge you to memorize. This is highly likely to be on your exam, and this relates to diagnostic testing. So again, I would recommend you set up your table the same way every time and just memorize the formula. So here in diagnostic tests, we always have a gold standard. I always put my gold standard on top because it's the best. And then I put my new test on the left-hand side. The key values they're likely going to ask you to calculate are sensitivity, specificity, and predictive values. Sensitivity, you go up and down. If you set up your table this way, I had this dumb way of remembering this. I just remember this N, and I remember that the two N's go up and down. Okay, maybe that's dumb. But so sensitivity is A over A plus C. It's a proportion of those with the disease who have a positive test. Specificity, you go up and down again. It's the proportion of those without the disease who have a negative test. It's D over B plus D. Predictive values go the opposite way, go across. So your positive predictive value is A over A plus B, and your negative predictive value is D over C plus D. It's the proportion of those with a negative test who don't have the disease. Sorry, I'm just having trouble changing. Okay. Because A and C is the prevalence of the disease, so it's A and C here is how common your disease are. Prevalence influences negative and positive predictive value. So the more common your disease is, the better your positive predictive value is. And the more rare your disease is, the better your negative predictive value. So it's important for you to know that prevalence influences predictive values, but does not influence sensitivity and specificity. So likelihood ratios. This is the priapism of statistics. This is the question that they always like to ask, even though I think it has almost no relevance in what we do in research. So please just memorize this, because it has been a question on every single exam since I've started to test this. So likelihood ratio positive. How much the odds of a disease increase when the test is positive? Just memorize this formula, please. Sensitivity over 1 minus specificity. Likelihood ratio negative. How much the odds of a disease decrease when the test is negative? 1 minus sensitivity over specificity. So some other diagnostic test issues. These have not been questions on the exam to my knowledge, but they are syllabus points. So the receiver-operator curve is often used when we have a diagnostic test and we're trying to identify the optimal threshold. So when you have a diagnostic test, the more you increase the threshold, you increase sensitivity, but at the cost of specificity. So what you do is you set up these graphs of sensitivity by 1 minus specificity. If your test is no good at all, it comes across this diagonal. All tests, all ROCs are going to have some curve that goes between this line of this completely straight line, and a perfect test would hug the margins. And what you're really trying to do is you're trying to find a threshold that is closest to this left-hand corner. That's really what an ROC is. The other thing the board wants you to know is about clinical prediction rules. So we talked a little bit about using regression to develop a prediction rule, and they just want you to know that you can use signs, symptoms, and other tests to help in these prediction rules. So systematic reviews. This is one of my favorite methodology types. It's when you identify all the studies that address a similar question, and you can synthesize the data either qualitatively, so you can just describe the studies, or you can mathematically combine them quantitatively. And you quantitatively analyze them. This is called a meta-analysis. The limitations in doing meta-analyses is if your studies are too different, there's too much heterogeneity in the treatment effect, it may not actually be fair to combine them. And I think the bigger problem is actually publication bias. So clearly negative studies are less likely to be published. There are ways to look at that, but I'm actually more worried about publication bias in terms of endpoints. So I think investigators often do multiple tests that they don't talk about in their publications, and I think the ones that they publish are more likely to be positive, but that we don't have a good way to test for that. So the next area, principles of epidemiology and clinical research design. Again, these are the slides that go through the syllabus points and which slide they're referred to. I think Leo did this topic already in his chemotherapy talk, so talking about phases of trials 1, 2, 3, and 4. Phase 1 trials are intended to find the maximum tolerated dose. Phase 2 trials identify preliminary efficacy information, so is there enough interest to move on to a Phase 3 trial? Phase 3 trials are definitive efficacy studies and allows us to detect some common side effects. However, rare side effects can only be detected with Phase 4 studies or post-marketing studies. So I am now going to go through a bunch of different study types. Retrospective studies, I think you're all going to be familiar with those. Those are when the exposures and outcomes have already occurred. These are usually the first projects you ever do as a resident or a fellow. The strengths are they're feasible, they're inexpensive. The limitations are we have limited availability of information about confounders. We can't control, we have limited control over, no control over how or when the exposure outcomes are measured, and there's a potential for recall bias. Case series are also really common resident and fellow projects where we describe similar cases, treatments, and outcomes. These are also feasible and inexpensive. We cannot test hypotheses, and there's a real concern about selection bias. Cross-sectional studies are when we take a group of people and we measure our exposure and our outcomes on a single time point. These are also fast and inexpensive, and we don't have loss to follow-up since we're measuring our outcomes the same time as we're measuring our exposure variables. However, it's difficult to establish causal relationships, and we can measure how common things are, but we can't measure incidence. And incidence relates to some number or event rate over time. We have no time element in a cross-sectional study. So the next two study types, case control and cohort study, the key distinguish is how do you select your participants. In a case control study, we're selecting participants based on the outcome, not the exposure. So we identify those with and without the outcome, and then we look back to see how many had the potential predictor. So let's use that example I used before where we were interested in maternal smoking and infant ALL. Here I'm going to select 100 kids with infant ALL from the COG study database. I'm going to select 100, 200 controls. I might match for a bunch of variables like age and socioeconomic status and geography. And then I'm going to go back and ask those mothers, did you smoke during pregnancy? So the strength of a case control study is it's good for rare outcomes. So infant ALL is a great example of that. Or if there is a long time period between your exposure and your outcome variable because you identify your patients based on the outcome. However, the limitations are we can't estimate incidence or prevalence of the disease. We've set the prevalence, right? We've set 1 to 3 or 1 to 1 matching. We can only study one outcome at the time because that's how we've selected our participants based on the outcome. And importantly, case control studies are very prone to bias. They're prone to two types of bias. There's sampling bias, and sampling bias occurs when my control group is systematically different in some way than my cases. So let's say I've done that infant ALL study that I just described, and let's say I took all my controls from Canada and all my cases from the COG database. So there might be some systematic differences. I wasn't going to talk about your politics at all, actually, so we'll just keep going. So the other real problem is recall bias. So in a case control study, in that example that I gave you about asking mothers about smoking, you can imagine that patients with the disease are going to recall things differently or more acutely compared to those without the disease. So I said that in a case control study, we're selecting participants based on the outcome. In a cohort study, we select participants based on the exposure. So here what we would do is find a bunch of mothers who smoke, we'd find a bunch of mothers who don't smoke, and we'd follow them forward and see how many of those babies had infant ALL. We can do this prospectively or retrospectively based upon how the outcomes occurred already. So if we do it prospectively, that's really straightforward. Today I would just assemble a cohort of mothers. The problem is I now have to follow them forward I'd have to follow a lot of them forward, but I'd have to follow them forward for a couple of years to see whether or not their babies developed infant ALL. In a retrospective cohort study, all of this data have to be recorded in some database already for this to be a retrospective cohort study. So there have to be a database that enrolled mothers at their pregnancy and asked the question specifically, do you smoke or not smoke? And then you'd have to have some way to follow those babies forward to see whether or not they developed infant ALL. So the strength of a cohort study is that the time sequence strengthens the inference because the exposure must occur before the outcome. We don't have recall bias because we recorded that exposure variable or exposure status before the outcome occurred. And because there is a time element, we can calculate incidence. But the limitations are, especially with a prospective cohort study, it's very resource intensive and expensive. So randomized trials, I think we're all familiar with what they are. The real benefit of randomization, it ensures that known and unknown potential confounders are equally distributed between your treatment and control group. It also, if done appropriately, avoids selection bias so that your treatment and your control group should be similar. The strength of an RCT is that it's the strongest design to make inferences about therapy, and if done appropriately, it limits the influence of confounders and selection bias. Of course, it can be done inappropriately too. That's a different topic. The limitations of an RCT is that it's expensive, and usually they are less generalizable. Some other study types the board wants you to know about. Longitudinal studies are studies that track the same individuals over time with repeated measurements. Two prominent examples are the Framingham study and the Nurses' Health study. They're essentially natural history studies. The limitations are that it's hard to determine causation, and many people are lost to follow-up. Another study design is before and after study designs, where you evaluated an outcome before and following institution of an intervention. So, for example, hypothetically, you may be instituting EPIC at your institution as we speak, and we could be measuring physician work hours before and after. The strengths of this study design is that it's feasible. The limitations are there's probably other changes or other things that are occurring that can confound the relationship. There's also an entity called regression to the mean. So the concept here is that we're more likely to identify a problem when event rates are extraordinary or high. So you're more likely to think about instituting a CLABSI intervention when your CLABSI rate is really abnormally high. And so what will happen in that case is that your observation, your next time point, will be closer to the mean or reduced just by regression to the mean phenomenon. It may have nothing to do at all with your intervention. A crossover study, we've talked a little bit about this already, is where you evaluate an outcome in 2 time periods within the same individual. You typically randomize the order. You can do 1 crossover, you can do multiple crossovers, and if you do a number of crossovers, that's also called an N of 1 trial design. An N of 1 trial design is actually a really good way to identify if an intervention works for that individual. The limitations of a crossover study is that you need a chronic stable condition, you need an intervention with a short onset of action, and the condition can't be cured by the intervention. Some other study designs, open label studies, so not blinded or not placebo controlled. This is actually the most common study design in the children's oncology group. We very rarely conduct blinded studies. The strengths are that it's feasible. Ethics are much less of a problem with open label studies, but the problem with it is that the chance of co-interventions or giving kids in the control arm other interventions becomes much greater. There's a possibility of contamination, so you know those in the control arm don't have the intervention, so if you feel really bad for a patient, you might want to give them that treatment. And there's also the potential for observer bias, especially for subjective outcomes. A post hoc analysis is where you examine the data after the study's been completed for relationships that you didn't think about ahead of time. This is very worrisome to me because of the concern about multiple testing. You're highly likely to show something by chance alone if you look at enough things. And subgroup analysis is actually similar in some ways to post hoc analysis in that we're doing lots of testing to see whether effects are different in different groups of patients. And the strengths are you may legitimately show that a treatment works differently in one group compared to another. So you might find a drug works in children that doesn't work in elderly patients, or might work in favorable risk AML but not in unfavorable risk AML. But the problem is that there's a real multiple testing problem. And your things that you find on subgroup analysis are actually likely to be spurious. So bias and confounding are the 2 major threats to validity for any study. Bias is systematic error, and the 2 main types of bias are selection bias, or how you select your cohort, and measurement bias. Confounding is another important threat to validity. It's where you have some variable which is associated with your exposure variable and is a cause of your outcome variable, and that's not in the causal pathway. And as I said, both of these are really important issues when trying to interpret your study. So some ways to avoid bias. Randomization, if done appropriately, can avoid selection or allocation bias. Double blinding can avoid measurement bias. Standardizing measurement of outcomes can also reduce measurement bias. Confounding is something we think about with all of our trials. So let's look at our levofloxacin prophylaxis study and seeing whether or not that reduces bacteremia. An important confounder would be patient type. So patients with acute leukemia have more infections compared to patients who receive transplantation. So how could we address that confounding? Well, we could restrict our sample to just leukemia or transplant patients. That's one approach. I could stratify the analysis and analyze leukemia and transplant separately. Now that will work to handle the confounding, but that makes my sample sizes much smaller. I can stratify randomization. What this does effectively is make sure that I have equal distribution of leukemia and transplant patients in both my treatment and my control arms. If there's exactly equal distribution of my potential confounder by my treatment arm, it can't be a confounder because then it's not associated with my exposure variable. Or most commonly, we use multiple regression techniques to adjust for that confounder. So effect modification is also called interaction. It's where there are two exposure variables of interest. And in this example, we are asking the question of how body mass index and gender influence systolic blood pressure. And it really asks the question of, does the effect of one exposure variable depend on a second exposure variable? So in this top example, you can see that there is a positive relationship between BMI and systolic blood pressure in both males and females. In this case, there is not an interaction or effect modification because the effect is similar in both men and female. However, in this bottom graph, you can see that the effect of BMI is completely different in males and females. In this case, there is effect modification. So if you were to ask the question, what is the relationship between BMI and systolic blood pressure, that question wouldn't make any sense because it would depend on if you're a man or a woman. So the board wants you to understand how results may differ between distinct subpopulations or effect modification. So the next module is on causation. There is a distinction between association, which is the correlation between two variables, and causation, where the outcome is causally related to your exposure variable, like smoking and lung cancer. So the Bradford Hill criteria are the criteria that are used to evaluate the factors that strengthen the causal inference in observational studies. They include temporality, so does the cause precede the effect? The strength, is there a large relative risk? A dose response, as you give more, are you more likely to have the outcome? Reversibility, if you take it away, does the effect go away? Consistency, do we see the same effect in multiple studies? Biological plausibility, does it make sense? Specificity, is there one cause, one effect? And analogy, is the same relationship observed in different diseases? So incidence and prevalence. Incidence incorporates some unit of time, so it's the number of new cases per unit time. Prevalence is just the total number of cases. Screening, the factors that affect the rationale for screening are that your disease has to be common and important enough to affect screening. There has to be a pre-symptomatic stage of the disease that allows you to catch the disease before it's symptomatic. So is there a latent stage of the disease? Is there a test available? That's quite good. Will screening be beneficial? And is there a treatment available? If these don't exist, then the rationale for screening is very limited. So the next topic the board wants you to know about is decision analysis. So the decision analysis is a specific approach, it's a quantitative approach used to compare different treatment options. And essentially the outcome you get is which treatment option is expected to be associated with the best outcomes most of the time. So you've probably seen these decision trees set up. What you do is you set up a decision tree. You've got program A, program B. Program A has specific outcomes that occur with a specific probability. Program B has maybe the same or different outcomes that could occur. And then you measure some outcome associated with each program. So it could be length of life, it could be quality of life, it could be hospitalizations. And you simply do math to calculate what the expected outcome with program A would be, this is a process called folding back the tree, where you multiply the outcomes times the probability, you add the two branches together, and you end up with this expected value for program A. The strengths of a decision analysis is that it gives you a number, so it gives you a quantitative comparison between different strategies that can incorporate benefits, side effects, and costs. The limitations, they're actually really hard to do. That's not actually part of your board, but they are hard to do because you have to know a lot of data to be able to construct one well. They are less useful for individual patient making. They're more about establishing what your program should be. And many of the things that you need to conduct a decision analysis, like probabilities of different outcomes and the specific outcomes, such as quality of life, are simply not known. Cost analyses, so there are cost-benefit analysis where both benefits and costs are monetized, and this allows you to compare different programs to understand whether programs are worthwhile. There are also cost-effectiveness analysis, which incorporates costs and outcomes of different strategies, such as cost per quality-adjusted life years. So the board wants you to know what a QALY is. A QALY is simply the multiplication of your quality of life times your length of life. So let's say that, and quality of life is measured on a scale of 0 to 1, where 1 is perfect health and 0 is dead. So let's say that you were going to live for 5 years in perfect quality of life. That would give you a QALY of 5. If you had another strategy that had you live for 10 years with a quality of life of 0.5, 10 times 0.5 is 5. So those are exactly the same quality of life, although you can see that they're quite different in how they look. But from a quality perspective, they look exactly the same. And in cost effectiveness analysis, it shows you the cost to gain both quality of life and quantity of life. And the board just wants you to know that different perspectives are important when you develop these decision models. So individual, societal, and healthcare system perspectives. So in any of these decision analytical model sensitivity analyses are really important because your probabilities, costs, and outcomes are all uncertain. So in the end of the day, you're going to say strategy A is better or strategy B is better, but how sure are you that A is better? What you do is you do a sensitivity analysis where you vary the probabilities and outcomes within some plausible range to find out, is your conclusion robust to the various assumptions that you made? If your conclusions change, then you're not so certain. But if your conclusions don't change, you're much more confident that your findings are correct and that strategy A is the best strategy. So now we're on to a new topic. We're on to measurement. There are two key concepts in measurement to know about: reliability and validity. Reliability is consistency or reproducibility, and it's a test property. So the types of reliability are test, retest. So in other words, you apply the scale, you do it again later at some other point in time with the same person, and you see, do you get the same score over time? This, of course, assumes the status has not changed in that time period. And inter-rater reliability is when you have two raters rate the same patient. So typically the child and the parent, or a parent and a healthcare provider. And for dichotomous outcomes, we measure agreement using the kappa statistic. For continuous outcomes, we'll use something called the interclass correlation coefficient. Cronbach's alpha is a different type of reliability. So this is used when we have a multi-component construct like quality of life, where we've got different components like physical health, emotional health, social health, and school health. And what we're trying to do is say, how much do each element in our overall instrument relate to the overall score? So it's a sign of internal consistency. So validity, as opposed to reliability, asks the question of, does your measure actually work? Does it measure what it's supposed to measure, or is it accurate? There are multiple ways to look at validity. There's internal validity. So the internal validity relates to, is my study finding correct? Do I have biases within my study that would make my conclusions wrong? External validity says, okay, I am now happy with my study findings, but is that generalizable outside of my study? And it really relates to generalizability. The other items for validity are quite different, and these really relate to instrument development, and we can go through them. So they typically relate to when you're developing in your measure, like a patient-reported outcome measure or quality of life measure. So face validity says, do the items make sense? So for example, let's say I was developing a new quality of life measure and I wanted to include hair color as an item. You probably would say that doesn't make sense to me. I don't think hair color should be an item. Content validity says, does the instrument seem to contain the items it ought to? So let's say my new quality of life measure, I omitted physical health and I only had emotional and social health. Well, you probably would say, I think you probably should incorporate some measure of physical health in this quality of life scale. Criterion validity occurs when there is some gold standard for your test. That doesn't occur so much with patient-reported outcomes. That's more with biological tests. But when there is a gold standard, you just look at the correlation between your new test and your standard test, and that's what criterion validity is. Construct validity is when there is no gold standard. So if there's no gold standard, how do you figure out whether your quality of life measure actually works? The way that we do it is something called construct validation. So I make hypotheses about how I think my instrument should work. So I might say, for example, I think quality of life should be worse in hospitalized kids compared to healthy kids. I think quality of life should be worse in kids who are blind compared to kids who aren't blind. And then you test your hypotheses. And if your hypotheses pan out, then this supports construct validity. Predictive validity is just the extent to which a score predicts some criterion measure. So here is the last section. The last section is actually very repetitive of what we talked about earlier. It brings just a different lens in specific items, so we'll go through this quite quickly. So these are that's the overview slide for the board's objectives. So we've talked already a lot about internal validity, so to the extent to which your trial results are true. So this section talks about the appropriate control group for case control studies, and we've already talked about selecting the right controls is a real source of bias in case control studies, and that you have to select controls from a population at risk that are otherwise similar to cases. Similarly, in cohort studies, your control group also must be from a group that is otherwise similar to your exposed group. In terms of internal validity, we also need to talk about surrogate endpoints. So surrogate endpoints are very commonly used in trials. These are lab tests or physical findings that are used as your primary endpoint instead of clinically meaningful endpoints. And the reason we do that is because they are more likely to be positive and more likely to be positive earlier, which makes our trial shorter and makes our trial more feasible because we need smaller sample sizes. But the limitations are that the effects on the surrogate endpoint may not correspond to the effect that you're really interested in, which is a clinically meaningful endpoint. So the next is intention to treat analysis. So the idea of an intention to treat analysis is that you analyze in a randomized study all patients in the group they were initially randomized to, not whether or not they received or didn't receive the intervention. And this is important because patients don't cross over randomly, and if you don't do an intention to treat analysis, then your results will be biased. An intention to treat analysis should always be your primary analysis. We've already talked a lot about power, I think, earlier. It's the probability your test will reject the null hypothesis, and the larger your sample size, the more power you have, and the greater your ability to detect adverse events. Sample size calculation. So in order to calculate a sample size for a controlled trial, we need to set the two types of errors. So we have to set our alpha error, so that's by conventions at P of 0.05. We also have to set our beta, which is by convention a 0.1 or 0.2. So this would translate to a 20% probability of not finding a difference if one really existed. And then we also have to set what difference are we looking at for between groups. And the way that we should do that is by defining our minimal clinically important difference. Now, this isn't what's normally done, nor is this necessarily easy. So the way to figure out what a minimal clinically important difference isn't actually well established, but that's what your sample size calculation should be based upon. And then the last thing you need to know for continuous outcome is how variable are your data. So we talked about internal validity. We also have to think about external validity. So how generalizable are the results of our study to other populations? So the factors that can jeopardize generalizability is if we have a highly selected population for our study, and this typically occurs in explanatory randomized trials. If the intervention is applied in a way that's not feasible in routine practice, if there are maneuvers to enhance compliance, or if there's lots of monitoring. So there are two types of randomized trials. There are explanatory trials and there are pragmatic trials. Explanatory trials are the kinds of trials you're used to in pharmaceutical labeling trials. These are the least generalizable trials. These are highly regulated, very optimal setting trials. The other end of the spectrum are pragmatic trials, which really are intended to mimic real-world practice and find out if the trial will work in the real setting. If the study sample is not generalizable, we have a problem because our findings may not actually be translatable to the patients we treat. So the influence of different types of data sources. If our outcome is a patient-reported outcome, we often will use diaries of some sort to collect data. These often are plagued by missing data, but there are ways to approach this. Recall bias can occur if people fill in their entire diary at the end. I think in this era of patient-reported outcomes that are electronically based, I think that is less likely to occur. The other type of data source the board wants you to know about are you doing data with administrative data. This is a whole other type of research, health services research, using billings data and discharge diagnosis codes to answer clinically meaningful questions. There are lots of challenges to using administrative data. All aspects of the research project, the validity of specific diagnoses has to be validated. So for example, if I'm trying to isolate a cohort of kids with ALL using specific discharge diagnosis codes, I need to validate that approach to make sure I am indeed capturing kids with ALL. These administrative databases typically lack clinical information that we would want, such as disease risk status, CNS status, other risk stratification, MRD, and there are errors in administrative data because they're collected for a different purpose. The next section the board wants us to talk about our application of information. We've talked about a lot of this already. The post-test probability of disease equals the pre-test probability of disease times the likelihood ratio. So just the idea of using what you knew beforehand or your prevalence of your disease to calculate your post-test probability of disease. We've already talked about your absolute risk reduction, what that is. That's equal to your risk in the control group minus the risk in your treatment group. That was on slide 21. And we already talked about your number needed to treat was 1 over the absolute risk reduction. In terms of significance, there are two types of significance the board wants me to talk about. There's statistical and there's clinical. Statistical significance is what we set with our alpha or our type 1 error. Typically, we are more likely to meet statistical significance if our sample size grows. But then there's a clinically meaningful difference. So you show a statistical difference in your study of 100,000 patients. Is the difference between groups really important? And that's a much more difficult concept, and that's actually related to that concept of minimal clinically important difference that I alluded to earlier. So using the medical literature. So using the medical literature is sort of fundamental through all of research, particularly so if you're doing systematic reviews. When doing systematic reviews, you need to go to your librarian with a clear searchable research question. And this final part, I've never seen it come up on the boards, but it's sort of an easy to test concept. So the best trial design for a specific purpose. So if you really want to know about the benefits or harms of an intervention, randomized trials are the best. If you really want to know about prognosis, cohort studies are the best. And if you want to know about diagnostic tests, cross-sectional studies are best. And that is it. I think I'm over. Maybe. Thank you.